Yeah, I would say that I think the results really kind of blew my socks off and were unexpectedly positive. So just as a reminder, this is a study for patients who receive standard of care trimodality therapy for esophageal cancers. In other words, preoperative chemotherapy and radiation followed by surgery. And for anyone who has either an adenocarcinoma or squamous cell cancer, for any patient who has residual disease, or in other words, did not achieve a pathologic complete response, they were then randomized to nivolumab versus placebo. And remarkably, there was a doubling of the progression-free survival for nivolumab. It went from about 11 to 22 months. And I think that really was certainly to me, a wholly unexpected result. We know that in the metastatic setting, these drugs are active, but they have relatively modest activity. To double progression-free survival, in this context is really pretty amazing. The study enrolled both squamous cell cancers and adenocarcinomas. It did look like squamous cell cancer patients had more benefit, but the adenocarcinoma patients also benefited. And that's certainly consistent with the fact that in the metastatic setting, we think that these drugs are a little bit more active in squamous cell cancers than they are in adenocarcinomas. The one thing I would point out is that, in one of the subset analyses, they did look to see whether patients who were node negative at the time of surgery versus those who were node positive had the same degree of benefit. And the patients who were node positive clearly benefited. It didn't seem like there was as much benefit for the patients who were node negative, but part of that may be incomplete follow-up. And the reason why I bring this up is that we do know that, at the time of surgery, patients who achieve a pathologic complete response have the most favorable prognosis. Therefore, those patients were not eligible for this study. But even for patients who have residual disease, those who have lymph node positivity have a worse prognosis than those who are lymph node negative. So I think it still remains to be seen, and I think we'll have to tease it out carefully to see whether truly everyone with any bit of disease left over benefits, or maybe whether it's the more high-risk patients who have the node positive disease who benefit. But certainly for now, I think that this is absolutely a game changer, and I think it establishes a new standard of care. I would also quickly add that I think it reinforces studies that are planned or ongoing that are now looking at adding immunotherapy to the chemotherapy and radiation before surgery. Many of these studies also give immunotherapy after that. So I think ultimately I think that there is going to be a role for immunotherapy in the curative setting of locally advanced esophageal cancer. And again, I mean, that's really also, that's really a sea change and a landmark. And I think part of the interest in moving it up and combining it with chemoradiation is that the study did accrue pretty slowly, because a lot of patients actually don't recover in time after chemoradiation and surgery to receive any additional treatment. So, we know that, in many situations, front-loading the treatment prior to surgery, makes more sense from a feasibility and logistic perspective. And I think that this study will certainly be the impetus and the justification for at least moving some of the component up front before the surgery itself.